Hello, everyone. My name is Lilia Adra, and I'm a P4 at Texas Tech University School of Pharmacy. My in-service today will be about neonatal abstinence syndrome, or NAS for short. Our objectives for today are to describe the pathophysiology and epidemiology of NAS, understand current treatment of NAS, and evaluate new literature regarding NAS assessment. Let us begin by defining and understanding NAS. During pregnancy, there are mothers that abuse various medications. This exposes the fetus to the substance while in the mother's womb. Once the baby is born, the baby could experience NAS, which is conditions of withdrawal caused by the abrupt discontinuation of fetal exposure to substances abused by the mother in utero. Unfortunately, NAS is diagnosed every 25 minutes in the US. With the current opioid epidemic, there has been a rise of opioid prescribing. In the US, there was a rise of 333% of mothers abusing opioids during pregnancy between 1999 and 2014, and this number is thought to continue rising. This correlates with the increased diagnosis of NAS and increased NAS NICU admissions. There are many drugs associated with NAS, but the most common drug class is opioids. In addition to opioids, some mothers abuse antidepressants, benzodiazepines, barbiturates, heroin, and cocaine. It is important to note that polysubstance abuse is also common, and some mothers also abuse nicotine and marijuana, and this can alter the severity of NAS expression in newborns. It is known that medications can pass through a mother's bloodstream through her placenta to the fetus. The pathophysiology of NAS is not fully understood. However, it is thought that there are several neurotransmitters that play some role in the clinical picture of NAS. For example, during withdrawal, the baby can have decreased serotonin, which would present as sleep deprivation, or the baby could have decreased dopamine that would present as hyperirritability. In addition, factors such as maternal and placental pharmacokinetics can also play a role in the amount of opioid receptor expression initially, and that is fully genetic. All this can play a major factor in the neonate's total withdrawal clinical picture. The withdrawal symptoms of NAS may begin as soon as 48 hours after birth. Sometimes signs of NAS do not show until 6 to 10 days after birth. An interesting point is that prematurity reduces the severity of NAS because preemies would not have been exposed to the substance in the mother's womb as long. Clinical signs and symptoms of NAS really depend on the affected system. If the neurologic system is affected, for example, we would see tremors, irritability, high-pitched crying, seizures, increased yawning and sneezing. If the GI system is affected, then we'd see poor feeding, vomiting, diarrhea, poor weight gain. If the autonomic system is affected, then we would see fever, temperature instability, sweating, nasal stuffiness, and mottling. Gestational age, maternal nicotine use, genetics, the type of drug that was abused, and how long ago the drug was used are all factors that affect NAS severity in the patient's clinical picture. Clinical diagnosis is really based off of an accurate report of the mother's history of her drug use. If that is not available, then we can test for the presence of drug in the infant. We can look at the infant's urinalysis, and that would reflect substance exposure in the past several days, but it has a high rate of false negatives. We can also look at the meconium toxicology screen, and that shows us exposure in the past couple of months. But getting a meconium sample from a newborn can take days. We can also look at cord blood and hair, but those are less sensitive and their clinical use is really limited. After a diagnosis is made, they use the Finnegan Neonatal Abstinence Scoring System, or the FNAS scoring system, in order to be able to make a determination of the grade and the severity of the patient's withdrawal. So let's talk a little bit about the FNAS scoring system. This is a scoring tool that's used to quantify the severity of withdrawal. The score reflects the infant's behavior based on 21 clinical signs and symptoms that are evaluated. A picture of those signs and symptoms is provided on the right hand of the screen. They begin screening within 3 hours of life of the newborn. If the newborn has a score of greater than 8, then this suggests the initiation of possible treatment. They continue scoring the baby based off of this scoring system every 3 to 4 hours. There's also a new assessment model that's called the Eat, Sleep, Console model that I'd like to discuss later in my slides. Non-firm treatment for symptoms really is based off of symptom relief. So if the baby is fussy, then we'd want to focus on soothing him by swaddling the baby and holding the baby. If the baby has low weight gain, then we'd increase his formula to a high caloric formula. If the baby is experiencing a lot of vomiting or diarrhea, then we would supplement the baby with IV fluids. This slide shows the current pharmacological treatment options for NAS. One of the most common treatment options is morphine, and it is the drug that is used at my current hospital rotation site. Other options would be methadone, buprenorphine, phenobarbital, and clonidine. Buprenorphine has showed positive results in studies that helped with a reduced length of hospital stay. The doses are provided on the table, but I'd like to talk about morphine. The initial dose for morphine would be 0.03 to 0.1 milligrams per kg every 3 to 4 hours. To wean morphine, we would taper the dose normally by about 10 to 20% every 2 to 3 days. This is what's done currently at my institution, and it is a common practice that is followed at other institutions. However, there is no set practice guidelines explaining the weaning process. With the FNAS scoring system, we would be monitoring the patient's signs and symptoms to see if the severity of NAS has gone down. While we're monitoring, we would want to determine if it's time to wean off the patient from pharmacotherapy. There's really no standardized weaning protocol among all pediatric hospitals. NAS signs and symptoms should be monitored for 72 hours after weaning the patient off of opioid treatment. I'd like to take a moment to discuss this piece of literature that is called Reduction in Length of Stay and Morphine Use for NAS with the Eat, Sleep, Console method. This study was published in 2018 in the Hospital of Pediatrics journal. The objective was to reduce the average length of stay and reduce morphine exposure in NAS patients. They used the Eat, Sleep, Console method instead of the FNAS scoring system for withdrawal symptoms in infants that were greater than 35 weeks of gestation age and confirmed opioid withdrawal. The Eat, Sleep, Console method approach evaluates whether an infant is able to eat at least 1 ounce per feed or breastfeed well, able to sleep for at least 1 hour undisturbed, or able to be consoled within 10 minutes. The results of this study was that the average length of stay was reduced from 10.3 to 4.9 days, and the average morphine administered decreased from 8 to 0.3 doses per infant. The conclusion of the study is that the Eat, Sleep, Console method reinforces non-farm care, reduces the use of morphine, and decreased the average length of stay for patients. So they assumed that this was a better scoring method for the assessment of NAS in patients compared to the FNAS scoring method that we talked about earlier. So on this slide, I've provided a picture of the Eat, Sleep, Console assessment method. Notice that this method is evaluating less things than was evaluated on the FNAS assessment scoring system. So here, one of the major factors that we're looking for is the amount of non-pharmacological care that is provided to the neonate, which I really like. The non-pharm care includes things such as skin-to-skin contact, swaddling, rocking, feeding, and rooming with mom. With this assessment, we're really avoiding waking the baby up. The baby can stay asleep as we monitor how they're doing and rate their current severity. I really like this compared to the FNAS method for these reasons, but I'll discuss more reasons on my next slide. While I do really like the Eat, Sleep, Console assessment method, I would recommend more randomized controlled trial to evaluate the use of this assessment, just to make sure that the data does correlate with the benefits of its use before I make it as a full-on recommendation. I do believe that the FNAS scoring assessment method does have limitations, and this includes the fact that it's pretty subjective. They evaluate sneezing and yawning, which I do not think warrants the use of morphine. The patient must be awake for accurate assessment. The FNAS doesn't really promote the use of non-farm measures. I showed on my previous slide how the Eat, Sleep, Console assessment really evaluates the use of non-farm measures, which is really nice before we add more morphine. And the FNAS doesn't really partner with family as its main goal, while the Eat, Sleep, Console assessment really does. My conclusion is that NAS NICU admissions have increased in the past decade. Morphine is one of the most commonly used primary treatments for NAS, as it serves as an opioid replacement. I recommend that we have more well-designed randomized controlled trials to show us the most optimal assessment tool, whether that is the Eat, Sleep, Console versus the FNAS, or others that are currently being developed, and also more randomized control trials for treatment for this population so that way we can provide neonates the safest care. I'd also recommend increasing the use of non-farm measures for treatment of agitation before we jump onto morphine. Thank you so much for listening to my in-service about NAS today. I hope that you learned something with me. This is a list of the references that I used to put this in-service together. Thank you so much and have a great day.